ಇಷ್ಟೇನಾ ಕಾರ್ಡ್ಲೆಸ್ ಆಯ್ತಾ
ಸೆನ್ಸರ್ ಅಲ್ಲಿದೆ
ಫೈನ್ ಫೈನ್ ಗುಡ್ hello hello can you hear me audible okay fine ಅದೇನೋ ಶಬ್ದ ಬೇರೆ ಆಗ್ತಾ ಇದೆಯಲ್ಲ ಹಾಗೆ ಇರುತ್ತೆ ಅದು ಢಮ ಢಮ ಹೊಡಿತಾ ಇದಾರಲ್ಲಪ್ಪ ಯಾ good morning to all of you. We're talking about a very important disease which everybody should know. It's not just an MBBS doctor who should know or a dental doctor. Even a common man has to know about this because we say India has become the capital of diabetes mellitus. Common man knows a lot about this. But here we are learning about diabetes mellitus in a scientific way. So what is this diabetes mellitus? You know, I've heard many children coming and complaining or at least talking about something interesting. So a child, I'll give you an example of a child who came and said that he saw ants around the urine sample of his grandfather. So that was the observation. So when these elderly people use the toilet also, there could be spillage of urine and why were ants around this? And such a nice observation by that child. So now we need to know what is diabetes mellitus. So diabetes means to flow through. What flows through? So much of urination, polyuria we say, and mellitus. Mel means honey. So it is sweet. Urine is sweet. Why? Because we have already taught you about glycose, urea, and the sweetness of urine. Of course, you and me have not tasted it but tested it. So can you recall what is the test we have done to detect the presence of glucose in the urine? Age-old practice of doing Benedict's test. Still we make you do that. But there is now strip reagents that are available. Just dip it in the urine and all the strips are coated with glucose oxidase and the substrate. So change in color indicates whether there is excessive amount of glucose that is excreted or not. So diabetes mellitus, remember, means diabetes is to flow through. Mel means honey. So it is a disease where the urine is sweet. So this has in ancient Ayurveda a mention about this. See, I just read out this in Sanskrit for you. Bhavishyato meha ganasya rupam mutre bhidavanti pipilikacha. Pipilika is ant. Dhavanti, they come, they get attracted. Mutre is urine. So meha, sweet urine. So this was quoted in Ashtanga Hridaya. So due to the presence of sugar in the urine, the ants and the flies appear to take the taste of it. So you should never forget what diabetes mellitus means. Okay. So with this introduction and to get you all into this topic, now I'll move on to the next aspect. So the objectives of today's session are, so I'm going to talk about the definition, classification of diabetes mellitus, pathogenesis, actually etiopathogenesis of the disease, and the laboratory diagnosis. That means at the end of this session, all of you, it is you, dear students, you should be able to define what is diabetes mellitus, and you should know to classify diabetes mellitus, and you should know etiology and pathology. So what is the cause for this and what happens? So etiology is what is the causation of the disease. Pathology, pathogenesis, the evolution of the disease. So how the disease occurs and how do we diagnose it? So when we talk about diagnosis, so here I concentrate on the laboratory diagnosis, the important features. So definition, yes, there has to be a standard definition. We understand the disease, but we cannot define it in our own words. So general pathology, I tell you, a lot of definitions you need to by heart. So it has to be the same words and the same sentences so that you easily score even 2 marks, which is allotted per definition. So as per WHO's definition, diabetes mellitus is defined as a heterogeneous metabolic disorder. Heterogeneous metabolic disorder. So one important word here, that is metabolic disorder. So remember this. So we call diabetes mellitus as a non-communicable disorder, non-communicable disease. So what are the characteristics then? It is characterized by chronic hyperglycemia. Chronic, that is over a prolonged period. So what is present? Hyperglycemia. What is hyperglycemia? Increase in the level of the blood glucose. And what else? It is not just hyperglycemia. There's a disturbance in the carbohydrate, fat and protein metabolism. Okay, so WHO defines diabetes mellitus as a heterogeneous metabolic disorder characterized by the common feature of chronic hyperglycemia with disturbance of carbohydrate, fat and protein metabolism. So you can pause at this level and then read the definition at least 2 to 3 times to register it. Now, same thing I'm repeating. So it's a group of metabolic disorders. So what is the characteristic feature? We said chronic hyperglycemia. That is nothing but high blood sugar level. So high blood glucose level. Chronic, that means over a prolonged period. So just look at this pictorial depiction. This is glucose in the blood. Normally, how much is there? You can see the dotted structures there. And what happens in hyperglycemia? See, there's so much of glucose here. So symptoms of high blood sugar include frequent urination, increased thirst, and increased hunger. So what do we call this as? So what are the classical symptoms of diabetes mellitus? We say polyuria. The person micturates urine, micturates several times. That is, passes urine several times, polyuria. So what happens with this? Polydipsia. So he drinks a lot of water, feels so thirsty, and polyphagia. It's like water everywhere, not a drop to drink. You are in the midst of sea, but you can drink the sea water, right? So much of blood glucose level is there in the blood, but still it is not utilized by the cells. So polyphagia is to eat more. So the classical triad of diabetes mellitus is polyphagia, polydipsia, polyuria. So remember these 3 classical features of diabetes mellitus. So why should we know about this disease? Because every family has at least one person who is diagnosed to have diabetes mellitus, but there's no scare. Please don't get scared or don't scare others because it is a treatable disorder. So we say we have to live with diabetes mellitus. How? So we have to take proper medication. So there's a lot of physical activity or change in the lifestyle that we need to follow, and then medication. So if one keeps the blood glucose level at a normal level, then definitely whatever is the period we are supposed to live on this earth, God has sent us to live for that particular period. So we can definitely live with it. So diabetes mellitus lives like a friend who is within us. So no scare, but if not treated, not diagnosed, then it causes lot of complications. So nobody should land up with complications. So it's the duty of everybody, all of you, to educate people with diabetes mellitus also. Not just know this topic for the sake of writing an answer in the examination and scoring. No, this has to be practiced. Okay, so if untreated, what happens? There is diabetic ketoacidosis, non-ketotic hyperosmolar coma, or death. And serious long-term complications, it affects all the organs in the body, including the skin. So, this leads to heart disease, stroke, that is related to the brain, then chronic kidney failure, foot ulcers, and damage to the eyes. So, retinopathy, diabetic retinopathy. Once retinopathy occurs, nothing can be done. So, earlier, the better. So, patients with diabetes mellitus need to be under the care of an ophthalmologist frequently, and a lot of oral complications also. And foot ulcers, diabetic foot is something which is very, very important. So, we teach them how to take care of the foot because there is peripheral neuropathy. So, if the patient walks on a hard surface, if he gets injury, if it's bleeding also, he cannot make out because there is loss of sensation. So, this is, of course, another topic. I don't think we go into detail about this. Okay, so that's about what did we learn? Introduction, interesting. Then we defined diabetes mellitus and in brief about the symptoms, very important symptoms. And now we are coming to the classification. So how is diabetes mellitus classified? So this is very easy to remember. Primary, secondary. Any disease we classify it as primary, secondary. So what is primary when the cause is not known? So what terminology we use for this? We say idiopathic. Then secondary when the cause is known. Okay. So that's one classification. Then second was juvenile onset and maturity onset. Juvenile is what? When diabetes mellitus occurs in children. That is juvenile. So maturity is in adults too. Then third is insulin dependent, non-insulin dependent. Don't you think these terminologies are self-explanatory? Insulin dependent, that means the patient is dependent on insulin. He has to take insulin every day to control that hyperglycemia. Second is non-insulin dependent. He doesn't require insulin, but he will be on tablets or other medication. So these three are the classifications which I learned probably and all your seniors learned a decade ago or so. But now this has become obsolete and undergone major revision due to extensive understanding of the etiology and pathogenesis. That means you know that there's something new, a newer classification of diabetes mellitus. Okay. So what is this new classification of diabetes mellitus? Where is the problem now for patients with diabetes mellitus? Pancreas. So where is pancreas? You know, on this side you can see this. This is the spleen which is on the left side and the tail being here and the head in the second part of the duodenum. So pancreas is the culprit. Why? Because it is not producing enough insulin or the cells of the body are not properly responding to the insulin produced. Two things. So the newer classification I was telling you, three main types, very easy to remember. Type 1 diabetes mellitus. If 1 you classify it as type 1, then there has to be type 2, right? So type 2 diabetes mellitus and gestational diabetes mellitus, and you can say others also. Gestational is what? Related to or associated with pregnancy. Yeah. So the broad classification, type 1 diabetes mellitus, type 2 diabetes mellitus, and gestational diabetes mellitus and others. So this is the classification. The chart, the table I have taken from your standard books. This classification is based on the etiology, based on the cause that has produced diabetes mellitus. So type 1, which is more common here. See, type 2 is more common, constituting 80%. So most of the diabetes mellitus patients you see belong to this type 2. Type 1 is just 10%. It was what previously which was called as juvenile, which is used to occur in children and who were insulin dependent or idiopathic. So type 2 is non-insulin, earlier classification, non-insulin dependent or maturity onset. So other specific types, okay. So we have taught you all this, the causes for hyperglycemia or glycosuria, endocrinopathies and acromegaly, Cushing syndrome, pheochromocytoma, all these are secondary. You need not remember. Just remember the causes for glycosuria, then you get. Then gestational diabetes mellitus. So pause this, look at the classification again. This is an etiology based classification. Okay. Type 1 diabetes mellitus. So now we know we have called pancreas as the culprit there. So type 1 results from failure of the pancreas to produce enough insulin. Failure of the pancreas to produce enough insulin. So this was the one which was previously called as insulin dependent. Cause we don't know, but next I'm telling you at least few causes why pancreas does not produce enough insulin. So where is insulin produced in the pancreas? Can you recollect? The endocrine pancreas, the islet of Langerhans and the beta cells. This is what you have learned in your first year, anatomy and physiology. Yeah. Type 1 diabetes mellitus constitutes just 10%. Previously called juvenile diabetes mellitus and insulin dependent. However, new classification is just type 1, type 2. Age is not considered, treatment is not considered. So based on the etiology now, type 1 is again further classified. So if a type is further classified, what do we call it as? We call it as a subtype. So there are two subtypes divided into two subtypes. You see here we are mentioning the etiology. So subtype 1, type 1A, diabetes mellitus is immune mediated. We know the cause here. So it is immune mediated. What happens here? The beta cells which I was just telling you. So beta cells are destroyed. They're the insulin producing cells. They're destroyed. So what destroys them? Autoimmune. That means that autoantibodies which have destroyed the beta cells. When the insulin factory itself is destroyed, what happens? It cannot produce insulin. That is type 1A subtype. So type 1B is idiopathic. So this is characterized by insulin deficiency with a tendency to deep ketosis. So when insulin is not produced, so it cannot control the glucose level, and then further, I'll tell you how complications occur later. And this mostly occurs, but here there is no autoimmune markers or no antibodies, autoantibodies. Type 1A has autoantibodies, type 1B idiopathic, no autoantibodies here. So this mostly occurs within the age of 30 years, although 5 to 10% of cases can occur in adults as well. So moving on to type 2, see such a nice depiction. I just clipped from one of the presentations. So this begins with insulin resistance, a condition in which cell fails to respond to insulin properly. So just take this analogy here, something different. So you kneel down and try to offer a rose to a girl. So you have so much of love, so much of affection. So you are offering, but the girl refuses. So how does it feel? Same thing, cells are there. So insulin is there, but cells are not responding. So here the girl is not responding to the rose offered. So exact same scenario here. So this was referred to as non-insulin dependent diabetes mellitus or adult onset. So insulin, the cells, probably the receptors, are not responding. So that leads to hyperglycemia. So primary cause here is excessive body weight and not enough exercise. So this is what we are inviting. So inviting trouble. So eating a lot of junk, putting on weight, not exercising. Now all of you must be knowing about something called a sitting disease. You know, we sit in one place, either in front of computer or with the phone or whatever. We don't move around at all. So more than 20 minutes, you're not supposed to sit in one place. That doesn't mean that you need to get out of the class after 20 minutes, okay? Yes. So excessive body weight. So why this girl, if you're offering a rose, does not accept, maybe she has some other boyfriend? No. Something else? She's expecting something else from you. So only after you give that, probably she accepts. This is just an analogy to say that insulin is there, but the cells are not responding, accepting. So receptor defect probably there. So type 2 diabetes mellitus comprises about 80% of the diabetes mellitus. This is what most of the adults or relatives, friends around you see who have this, not your age friends, elderly. So previously called maturity onset diabetes, non-insulin dependent diabetes mellitus of obese and non-obese type. So this affects older individuals. It also occurs in obese adolescent children. So obesity, please say no to obesity. It brings in lot of diseases. So we call it as metabolic syndrome in adults. Even if a child is chubby, don't be happy. See that the child is lean. So school programs, you know, when we take up the study, many children are found to be obese. So childhood obesity has to be ruled out or taken off. So moreover, many type 2 diabetes mellitus patients also require insulin. It doesn't mean that they don't require insulin. Some of them need insulin also and oral anti-diabetic drugs also. So gestational diabetes mellitus. So 4% of pregnant women develop diabetes mellitus. So this is due to metabolic changes during pregnancy. That's why in pregnancy, regularly blood glucose level or urine glucose level, glucose estimation or detection is done. And they revert back to normal glycemia after delivery. But only thing is, we say these women have a risk. That is, they're prone to develop diabetes mellitus later in their life. Okay. Shall we just look at the differences now? Hope no confusion. Type 1, type 2. Type 1 is sudden onset, children. This is gradual. We said chronic hyperglycemia, mostly in adults. So body size normal in type 1, obese. Ketoacidosis is common in type 1 because insulin, they're dependent on insulin. So here it's rare. Autoantibodies are present in type 1. Remember, subtype, first subtype, okay. Then here then absent. Then endogenous insulin is low or absent. It could be normal, decreased or increased also. Then concordance in identical twins, 50% of them develop this. So here 90%. And most common is, I said 80, but nearly 90% is type 2. Now, so what is the etiopathogenesis? Only once we know the etiology and the pathogenesis, the treatment becomes easy. And knowledge about this helps us to prevent this disease. So depending on the etiology of diabetes mellitus, hyperglycemia may result from how? One is decreased insulin secretion. Second is decreased glucose used by the body. If we eat a lot, sit at one place without exercise, why do the cells need more glucose? So decreased utilization and increased glucose production. So three things are important to cause hyperglycemia. Recollect this normal insulin metabolism, which you have learned in your first year. So type 1 diabetes mellitus, the pathogenesis, same thing I told you already, the concordance and all that. Yes. So we said pancreas is the culprit, organ which undergoes damage. But what causes damage here may be viral infection. So that is insulitis or experimental induction with some chemicals which are damaging, or geographic and seasonal variations, or query bovine milk proteins. Okay, so genetic factor is there. Then we said autoimmune. So there are antibodies to islet cells. So what do these antibodies do? They're auto-antibodies. They destroy the islet cells. So they cause insulitis and T-cell mediated T lymphocytes, CD8 plus lymphocytes mediated selective destruction of the beta cells. All these lead to type 1 diabetes mellitus. So when beta cells are destroyed, there is no insulin production here. What has to be done then? So we have to inject insulin. So daily the person has to take insulin to control the blood glucose level. So that is type 1. So when we look at type 2, see these are constitutional. So we say environmental factors, constitutional factors, obesity, hypertension, low physical activity. Obesity itself can give rise to all these other complications. Then concordance in identical twins is 80%. So now the question arises, oh, my parents have diabetes mellitus. Do I get diabetes mellitus? See, the chance is, if both parents are diabetic, then the chance of the child getting diabetes is 50%. So 50% of children can get this. But there's so much that lifestyle modifications if we adapt, so we can definitely prolong this, that is, occurrence of this disease. Then other causes are insulin resistance. I told you that. Type 2, remember the analogy, rose offering. So, or you just remember Valentine's Day, you will know if something you don't think of happens. That is like diabetes mellitus too. So receptor and the post-receptor defects, impaired glucose utilization. Other causes, why decreased insulin secretion in these individuals? Probably glucose toxicity or lipotoxicity or amylin. All these. So that means I told you water everywhere, not a drop to drink. So then when the blood cells are not getting glucose, then the responsibility is on the liver. So what does liver do? So liver starts producing more glucose. More glucose synthesis happens because it has to supply. It is there, not utilized. So that leads to hyperglycemia. This is pathogenesis of type 2 diabetes mellitus. Again, I have few more pictorial depictions to talk about this. Okay. Pathophysiology. So the body, how does body get glucose? Every cell needs glucose for its activity. That too the brain cells, we say they constantly require the supply of glucose, oxygen and water. So how do we get this? One is by eating. Do we just eat? Do we undereat? We overeat. So how much we should eat? Only our, stomach, we say half stomach full with food, another 25% with water, and another 25% should be empty, I believe. But we eat till it comes to the esophagus, so much. So when we belch also, probably the food will be coming out. We should not eat so much. So food is one, and what we eat, the glucose gets absorbed in the intestine. Then intestinal absorption of food is one. Then breakdown of glycogen. I was telling you how liver produces glucose. So this is glycogenolysis. Then gluconeogenesis. This is generation of glucose from non-carbohydrate substrates in the body. What happens if you starve continuously for 2-3 days? Do we die? No. The fat depots are utilized to provide energy. So these are the sources of glucose to the body. So insulin is a potential hormone that regulates the uptake of glucose by the blood into the cells. So insulin is important here, especially the liver, adipose tissue and muscle except smooth muscle. So in which the insulin acts via, of course, insulin-like growth hormone, growth factor 1. So what happens with insulin deficiency? Or type 2, what did we say? Insulin is there, but insensitive to the receptors. So it plays a role in all forms of diabetes mellitus. So insulin is important. Insulin has to be there for whatever glucose is there, for that glucose to be utilized by the cells. Otherwise, there's no use. So you see a well with water. You're thirsty. There is a well with very sweet water. How do you drink it then? You're very thirsty. How do you drink it? So you need a rope and a bucket to fetch the water from the well to drink it, right? So that is not happening here. Yeah, insulin plays a critical role in balancing glucose levels in the body. It can inhibit the breakdown of glycogen or the process of gluconeogenesis. So it's like inversely, it's like not inversely. So it is proportional. Insulin production or action is proportional to the level of hyperglycemia. So it can stimulate the transport of glucose into the fat and muscle cells. So it can stimulate the storage of glucose in the form of glycogen. So all these are actions that insulin plays. So insulin is released into the blood by the beta cells. Okay, so beta cells are the cells which produce insulin. Sorry for that. So from islets of Langerhans in the pancreas. So slowly, see, in response to this, they're secreted or released in response to what we eat or increasing blood glucose. So lower glucose levels result in decreased insulin release. So you can say insulin and glucose levels directly proportional. Then this process is mainly controlled by the hormone glucagon. Glucagon we know has an opposite action. That is, the glucagon action of glucose. Glucagon is opposite to that of insulin. So the amount of insulin available is insufficient if the cells respond poorly to the effects of insulin. It is insufficient. So the glucose will not be absorbed properly by the body cells if insulin is defective, and the net effect is high levels of blood glucose. So with this, there is poor protein synthesis and breakdown of fat storage. So fat starts providing energy to the body. So that leads to acidosis. Yeah. So when the glucose concentration in the blood remains high over time, the kidneys will reach a threshold of reabsorption. So what does that lead to? Glycosuria. So you know different tests you have tested the provided urine sample for presence of glucose. So glycosuria results, sweet urine. With this what happens? There is increase in the osmotic pressure of the urine. This increases osmotic pressure of the urine. So that leads to polyuria. The person micturates several times, passes urine several times. That is increased fluid loss. So with these two, what happens? The lost blood volume will be replaced osmotically from the water held in the body cells. So now this disturbance in the homeostasis, the water regulation. So what happens now? The body requires water. So there is the thirst center that is activated. So the dehydration resulting in polydipsia. So now the person knows that he has to drink lot of water. So this is a regulated mechanism. Are you able to follow? I'm just simplifying these things. Yeah. Now repeating the pathophysiology of type 1 diabetes mellitus. Now you know that insulin is not produced here. We have already dealt with the causes for beta cells not producing this, either destruction and autoantibodies and all that. So that leads to insulin deficiency. So this is two types, remember, immune mediated, idiopathic. So majority are immune mediated, in which T cell mediated autoimmune attack leads to loss of beta cells, and thus insulin production is not there. So most affected people are otherwise healthy and of a healthy weight when onset occurs. So why do we say healthy weight? Many of the diabetics you can see, they, because though they eat so much, they say I'm losing weight. That's one thing. Then sensitivity and responsiveness of insulin are usually normal in the early stages. So this can affect children, or at most often, remember children. If you remember this picture, yeah, most often it is children, but there's always an exception to the rule that it can occur in adults too. Yeah. So type 1, genetic, with a genetic factor, inherited with multiple genes including certain HLA genotypes which are known to influence the risk of diabetes. So in general, in genetically susceptible people, the onset of diabetes can be triggered by one or more environmental factors. So here with environmental factors, we add viral infection also. So among other dietary factors, gluten. Now, you know, people are so much sensitive to gluten, and they talk about this gluten-free diet and all that. So type 2, this is what I want you all to read, recollect again. Type 2 diabetes mellitus is characterized by insulin resistance. The defective responsiveness of body tissues to insulin is believed to involve the insulin receptor. Remember that analogy arose. Then in the early stages of type 2, the predominant abnormality is reduced insulin sensitivity. And underline this, lifestyle factors. Genetics, okay, we may not help. Parents have, yes, I need to get, but let me postpone getting this disease. But lifestyle factors. So I was thinking after COVID and lockdown and no maids to help us, no cooks. So we have all become active, I was thinking. So we are doing our own work. So much of lifestyle modifications that we have seen, but keep regular exercises, eat a healthy diet. So a number of lifestyle factors are known to be important in development of this. So obesity, lack of physical activity, obesity. Eat more junk food, obesity. Then poor diet also. So that is on the other hand. Then stress. What does stress do? Releases a lot of cortisol and all the secondary effects there. Then dietary factors also influence this. Sugar sweetened. Okay. So eat fruits instead of drinking fruit juice. Fruit juice, you remove the pulp, you filter and add additional sugar. Why? That has to be there. So if you want to drink juice, okay, fruits, no sugar, make a juice, don't filter, drink. Better to eat fruits. So then type of fats in the diet, the saturated fats and the trans fatty acids increase. So all of you are so much fond of eating those kurkure lays and all those, please limit it. All these have. So look at the labels written there on those. So polyunsaturated and monounsaturated fats decrease the risk. So we say any vegetable oil for that matter is good. Don't use refined oils also. Use filtered oils. Then eating lot of vitamins. I don't know. I need to look at the studies references for this. And a lack of exercise causes 7% increase means. So what is there? So keep your bike aside and vehicles aside and then walk till the college. That is the best physical activity, and brisk walking. So that's about type 1, type 2 diabetes mellitus. I've repeated the pathogenesis many times because this is such a common disease that all of us should be aware of. We should get a proper knowledge. So gestational diabetes mellitus resembles type 2 diabetes mellitus in several aspects. So this involves a combination of inadequate insulin secretion and responsiveness. I told you 4% earlier, so it can occur, so say affect about 2 to 10% of all the pregnancies. And these pregnant women after delivery may improve. Their blood glucose may revert back to normal. However, uh, but see, 5 to 10% women are found to have diabetes mellitus, most commonly type 2. It may not return back to normal. It all depends on their genetic factors also. So this diabetes mellitus which occurs in pregnancy is fully treatable but requires careful medical supervision and all this, management, whatever, including insulin may be given. And this we said is transient, but untreated, it damages both the tissues of the mother and the fetus. Okay. So when do we probably guess? So usually we do a test during pregnancy for the blood glucose, but otherwise a big baby. So when a baby is born, they say, oh, 4 kgs, 4.5 kgs. So macrosomia, high birth weight, that means the mother is prone for this diabetes mellitus. And such fetuses born or newborns born to diabetic mothers may have congenital heart defect, central nervous system abnormalities, or skeletal muscle abnormalities. Okay, so morphologic features. So what happens to, we said again pancreas is the culprit. So which part of pancreas? It is not the exocrine pancreas with gland and ducts. It is the endocrine portion. What is the endocrine portion? That is the islets of Langerhans. So what do we see there if we study this organ microscopically? So insulinitis. What do we see? Type 1, there may be lymphocytic infiltration because this is T cell mediated. Then some macrophages and so inflammatory cells. Just remember, inflammatory cells may be there. Whereas here, type 2, in the long run, there will be fibrosis. So what does fibrosis tell you? It's just a scarring. It's a telltale sign of previous damage. Whenever we have cuts or wounds on the body, it heals, right? So how do we know there was an injury which has healed? That is by the scar. What is scar? It is nothing but fibrocollagenous tissue, just the collagenization. That is what is being. Then islet cell mass, progressive depletion of beta cell mass, eventually resulting in loss of pancreatic beta cells. So here, no, beta cells are normal. The mass is either normal or may be mildly decreased. Amyloidosis. So deposits of amyloid are not seen in juvenile or type 1. So here they are seen. Remember amyloid we have taught you? It appears as pink, see, homogeneous, structureless material. Even collagen looks like that. How do we say it is amyloid? We do a special stain. What special stain? Congo red. What happens if this is amyloid? It takes up a red color. Are we happy just to say it is amyloid because Congo red has stained it red or the amyloid has taken red? No. There is another test that has to be done. The slide has to be observed under polarizing microscope. So we have to see apple green birefringence. This is the previous topic. So one of the tests for amyloid is Congo red. They appear red. On observation under polarizing microscopy, they appear as apple green. They show apple green birefringence. Yes. Contrasting features of type 1 and type 2. This already I have told you. So just pause this slide, go through the differences. Same thing which had been discussed earlier in the earlier slides, just summated everything here. So look at the differences, you get to know all the points again. This is for recollection. So pathophysiological basis of common signs and symptoms due to uncontrolled hyperglycemia. So now we know insulin deficiency, hyperglycemia. So water everywhere, cells are not getting, so if person feels fatigue, tired, that is what. And so much of glucose, what happens? If there's even mild bacterial infection, they nicely flourish because they get a lot of food to eat. So all infections occur. Then increased catabolism, so hunger, and because of catabolism, weight loss, wasting. People ask why you have lost so much of weight. Yes, lipolysis. Fat is giving energy to the cells. Then decreased anabolism, osmotic diuresis. That is the one which is causing polyuria, polydipsia we discussed earlier. Then with all this tachycardia, hypotension, diabetic coma and death. This is uncontrolled diabetes mellitus. Not treated properly, then these complications of diabetic coma, ketoacidosis and death can occur. So these are just the symptoms, and even so with all the symptoms, if you see somebody, you suspect, so get them investigated. So without investigation, confirmation, don't tell them you have diabetes mellitus, okay? So long-term complications, I told you, cataract retinopathy, coronary arteriosclerosis or IHD, ischemic heart disease, see, autonomic dysfunction here, diabetic nephropathy, kidney, kidney damage and diabetes mellitus is so important. It's called as diabetic nephropathy. Diabetic neuropathy, peripheral neuropathy, this is what, many patients suffer from peripheral, they say pain and burning and all that. So, occlusive atherosclerosis. So, with this ischemia, we have taught you gangrene and diabetic ulcers. So, these are the complications, long-term complications of diabetes mellitus. So, just pause at this level and then look at this picture and read the complications again. So, now I have come to the last objective. So, I told you diagnosis of diabetes mellitus. So, in symptomatic cases, we examine the urine sample, dipstick, or we have automated machines which say there is glycose urea or glucose urea. So, what do? We don't just diagnose or label them as diabetics. So, we just take a blood sample. So, if it is not taken on fasting, if it's a random sample and done, so the plasma glucose concentration above 200 mg per deciliter, so we get a suspicion now. Then the severity of clinical symptoms of polyuria, polydipsia is directly related to hyperglycemia. So asymptomatic cases is persistently elevated fasting plasma glucose level. Then we have to further do some tests to diagnose. So how do we diagnose now? So get a fasting blood glucose done. What is fasting glucose? So we say at least minimum 8 hours or 12 hours is fine, fasting glucose level. If it is more than or equal to 126 milligrams, okay, so we diagnose diabetes mellitus. Plasma glucose, you should remember, it is slightly higher than the blood glucose. So 2 hours after, so this is GTT. Have you heard about GTT? I'm sure it's been taught to you in biochemistry. So glucose tolerance test, oral glucose tolerance test. So give the person 75 grams of glucose to drink. Usually we give glucose and add water and ask them, it's so difficult, so sweet to consume it, but somehow. So after that, 2 hours after consumption of this, estimate the glucose level in this. So if it is 200 milligrams per liter, more than or equal to, so then we say it is diabetes mellitus. Symptoms of high blood glucose and casual plasma glucose. So when blood glucose at a random blood glucose, when it is done any time of the day, if it is 200 milligrams or more, we suspect there. Best is there's something that another test that has to be done. It's called as glycosylated hemoglobin, Hba1c. So if it is more than or equal to 6.5. So these are general routine investigations. Everybody gets it done. So it's a revised criteria, please remember, for diagnosis of diabetes mellitus by oral GTT as per American Diabetes Association. So fasting blood glucose, that is for more than 8 hours fasting. If it is below 100 milligrams, that is normal. Okay. So 100 to 125 milligrams, we say there is impaired fasting glucose. If it is 126 milligrams per deciliter or more, we say diabetes mellitus. See the criteria, how the values have come down. So when I was a student, or even after so many years, so 100 to 120 milligrams is considered as normal. So now the levels have come down. It is less than 100. Okay. So register all these values now. Then 2 hours postprandial, that is after giving 75 grams of oral glucose load. So normal, we have to find it less than 140 milligrams. If the values come to 140 to 199, then we say impaired postprandial glucose tolerance. If it is 200 milligrams or more, then we say the person has diabetes mellitus. So random value, I told you, sample of blood taken during the day, any time. If the value is 200 milligrams or more in a symptomatic patient, then we consider him as diabetes, having diabetes mellitus. And you should know that what samples are taken. If plasma glucose is taken for estimation, these values are 15% higher than the whole blood value. So glucometers you have seen, where we just puncture and take. So that is a whole blood. It could be slightly about 10 milligrams less than what we get with the plasma values. So the following investigations are helpful in establishing diagnosis of diabetes mellitus. Urine testing. You're all experts. You know how urine is tested for the presence of glucose. You know the causes of glycose, urea. Yes. So urine tests are cheap and convenient, but the diagnosis cannot be done only on that, because we know that there are non-sugars which also give the false positive test. But with the strip reagent, there's no false positivity, because glucose oxidase, we say, is a specific test for glucose. So they can be used in population screening service. So urine is tested for the presence of both glucose. Whenever glucose is positive, they've told you to test ketone bodies, especially when glucose is more than 2%, Benedict's positivity. So Benedict's qualitative test detects this. Now we say all this is outdated. So Benedict's semi-quantitative was what is being taught to you. The main advantage of relying on urinary glucose test alone is, say, to know the renal threshold. But if patients are on treatment, okay, we can tell them to go ahead with the strip reagent test. A diabetic patient may have a negative urine glucose test, and a non-diabetic with low renal threshold may have a positive test. So what is renal glycosuria? Some terminologies let us know. After diabetes, the next most common cause for glycosuria is decreased threshold of glucose. See, look at the renal threshold, normal curve up to 200. So here it is decreased. So once it reaches that level itself, glucose is excreted. So that is renal glycosuria. What is alimentary glycosuria? Okay, imagine all of us have had a very nice meal, okay, in a marriage or some party. You know what all you eat in a party? No, dessert, especially dessert is something which is given importance. Or you eat some 4-5 ice creams and one benedosa and all that. So test the urine sample for glucose after a nice lunch or eating all this. So everybody's urine will show positive glucose, will be positive for glucose. So rapid and transitory rise in the blood glucose level above the normal renal threshold may occur in some individuals. Usually it happens, though it is said that in some individuals. So during this period, glycosuria is present. So this is called as lag storage curve or alimentary glycosuria. So don't be scared because the test has to be repeated later. So ketonuria. So the test for ketone bodies, remember the Rotheras test that you have done, where we get a purple ring that says positivity. So whenever there is glycosuria, so check for ketone bodies also. So especially in uncontrolled diabetes mellitus, ketonuria may appear in individuals. Ketonuria occurs. And we know the other causes for ketonuria also. This is a frequently asked question for you in the examination. So one is diabetes mellitus, uncontrolled. The other causes a prolonged starvation, prolonged vomiting, hyperemesis gravidarum. So pregnancy, in pregnancy, lady vomiting. So many times they're not able to consume anything. All these are the causes for, and glycogen storage disease. All these are the causes for ketonuria. So single blood sugar estimation. So whatever be the method. So the last sentence is important here. A fasting plasma glucose level above 126 milligrams per deciliter is certainly indicative of diabetes, and in other cases oral GTT be performed. So screening by fasting blood glucose level, it is estimated. Now we say for individuals who are more than 45 years, please do this test frequently or as a routine, now everybody gets it done once a year or so. So many of the cases meeting the current criteria of diabetes mellitus are asymptomatic and do not know that they have a disease. That's why we say screening is important. So why screening? They're asymptomatic. Second is early diagnosis. That's all. So studies have shown the type 2 diabetes mellitus may be present for about 10 years before symptoms appear. That's why we do screen. So course of the disease because gets altered with favorable treatment. So this is oral glucose tolerance test. I'm not going to tell you about this because you have already learned about it in detail in biochemistry. All this. So impaired GTT, I told you. This is the important sentence here. Read. Individuals with fasting value of plasma glucose higher than 126 milligrams per deciliter. So FBS, more than 126 milligrams per deciliter, and a 2-hour value after 75 grams of oral glucose, which is more than 200 milligrams per deciliter or labeled as diabetic. So this is the criteria. This is again another question that is asked you in practical examination. So in symptomatic cases, a random blood glucose value above 200 milligrams is diagnosed as diabetes mellitus. So this is the criteria. What criteria? Laboratory criteria to make a diagnosis of diabetes mellitus. So the last few words about what is glycosylated hemoglobin. You might sometimes get this as a short note. Just remember 2 or 3 points about it. So measurement of blood glucose level in diabetic sufferers varies. This is due to dietary intake the previous day, what they have taken and all that. So long-term objective assessment of degree of glycemic control is monitored. So why Hba1c is important? So it tells us about the long-term values of glucose. So how the glycemic control is there. Because the non-enzymatic Hba1c, non-enzymatic glycosylation of hemoglobin takes place over 90 to 120 days lifespan of red cells. So if we estimate Hba1c, it gives us a better idea about how the blood glucose was there for this person. Today, probably when we diagnose, it could be just 126 milligrams. But what happened previous over 120 days? So that we get an idea by estimating Hba1c. So this is glycosylated hemoglobin. This is a minor component which is present in normal individual. So the glycosylation of hemoglobin tells us about the control of or glycemic control or the blood glucose level and the control of diabetes also. Hba1c assay gives an estimation of diabetic control and the compliance for the proceeding 3 to 4 months. So increased Hba1c, that means diabetes mellitus, but not normal value, diabetes mellitus, but normal value does not rule out IGT, that is impaired glucose tolerance. So if Hba1c is increased, yes, so it's diabetes. And he has been having uncontrolled the glucose levels for over past 3-4 months. So moreover, since Hba1c assay has a direct relation between poor control and development of complications, it's a good measure of prediction of microvascular complications. So care must be taken to interpret Hba1c values because it varies with the assay method. That's why we need to have normal values also depending on the assay. So glycated albumin, I don't talk about this. So cortisone prime GTT, insulin assay, they're not required for you. C-peptide assay and islet cell, all these are further, not just for the diagnosis, laboratory diagnosis, but further research and to know more about the diagnosis of this diabetes mellitus. So we have come to the end of this topic. In general, I have told you what is diabetes mellitus. So we have defined diabetes mellitus as per WHO, the World Health Organization, and we have classified diabetes mellitus. Based on the classification, we have learned the etiology also, and we have looked at the etiological classification also. So in general, we have known about the symptoms, that is polyphagia, polydipsia, polyuria, and the changes that occur in the pancreas, and we have called the islets of Langerhans as the prime culprit in the pancreas that is damaged because of either autoantibodies or infection and all that. And very, very importantly, so why this thank you here? There's some action poses, right? So this tells us which factor? This tells us about the lifestyle modification. Very, very important. So to stay healthy, even if we have a genetic predisposition, to avoid to get this disease early, we have to adapt healthy lifestyles. Okay, so what is that? Eat healthy, then exercise regularly, and of course do meditation, because cortisol also we said stress factor, which is one of the cause for diabetes mellitus. So 3 things